Good morning and welcome to our ccclivecases.org. Today is a very special day. It's our first anniversary, and I want to thank the thousands of interventional cardiologists from more than 25 countries who have been watching us. From the last count I have, there have been more than 14,000 viewers who have watched the cases. Of course, today being case number 12, our first anniversary. And I'd like to take a moment to pause and reflect on what we may have achieved and what I believe may have become a forerunner for interventional cardiology, CME, worldwide. I think I can attribute that to a fantastic curriculum, a genuinely thoughtful, thought-provoking, didactic which covers all the pertinent issues, truly complex coronary intervention case, an example of which you'll see again today, and finally a very broad Q&A on the topic which covers the entire CME process. So I'm delighted. I thank all the viewers for their response. You can also access us live stream on the Apple iPhone, and with that introduction, I'm going to take you quickly to the cath lab where we have another fascinating and complex case. Samin, good morning and congratulations to your team for having put up a wonderful performance over 12 consecutive cases.
Well, Samir, thank you, and most important, thank to all of our viewers who have been very enthusiastic about this educational activity which we started. Of course, this is the 12th in a row, and totally unique. Now, of course, over the months and the last year, we have learned quite a bit what type of cases we should be selecting and so. And it turns out to be that viewers still want to see patients with a left main disease. That if we take our web hits of 4 cases which have been the left main, they actually have the highest starting with the July, almost close to 3,000 web hits. But the overall, actually, few of the requests have been that we should make it twice a month. I said, listen, once a month is quite enough. But of course, we do our June symposium, which is next week. We may modify based on various requests. But clearly, I take pride having this educational session started last year. And of course, it could only be possible by help of my cath lab staff, and most importantly by Dr. Keeney, and of course on my left side, who has been the prime operator in majority of these cases and try to focus on the educational aspect and the technical aspect of performance of the tough cases. So having said that, we actually have the kind of a grand finale of the toughest of all the 12 cases, and we can put the slide on this case, number 12, with an 86-year-old female presented to us first time in April with non-STEMI. Troponin was about 5 with the CHF, and she has a longest-standing history of prior MI, progressive CHF, mild aortic stenosis, and on appropriate medications for the anti-ischemic heart failure, and she also has rheumatoid arthritis for which she is on prednisone. The cath was done. At that time, there was no PCI actually. The cath was done with a 3-vessel disease, and EF is 20%, and the syntax score is 37, has a mild aortic stenosis of 12 millimeter gradient, actually comes out to be valve area about 1.8, mild pulmonary hypertension, wedge pressure was 22, and has a significant lesion in the LAD, left main, and circumflex, along with the non-dominant or moderate size right coronary artery. And actually, I think the most important would be that because of high syntax score, this patient was referred for coronary artery bypass surgery. Maybe Anu can take us through the angiogram, and we'll come back to this slide in 1 minute. Now, this actually is the picture. You want to come?
Yeah, this we just right was just moderate disease. We did not take a picture of her. Just to give you some update on her labs. So history of DVT, and she was on Coumadin. We stopped it as soon as we know the surgeons had declined her for surgery. Question for a PCI, which we were trying to medically manage her initially. Despite stopping Coumadin for more than a week, her INR has been 2.3. Her creatinine is been good with the diuresis, with the 0.8 today. And if you see the angiogram, is distal left main, like we did, was about 80 to 90%. And important is it's bifurcating, involving the ostial circumflex, and there's a disease in a big LPL branch, moderate disease, then it becomes about 80-90%. And then you have in the prox LAD again 95% disease, and as you see further down in the apex is diffusely diseased. She was referred from at another city hospital where she had a normal LV function 6 months ago. She presented about 3 months back with some dyspnea, and at that time she had some LV dysfunction, but subsequently multiple admissions with heart failure and non-QMI finally got transferred here to Sinai, which was a couple of weeks back, and here she is for the PCI.
Yeah, therefore we can go back to our slide. So basically, as our policy at Sinai, patients with a syntax score of 33 and above get a routine consultation unless they are having MI or very high comorbid conditions that end stage lung disease or CVA or some that patients are, then go for PCI. But otherwise, as a policy at Sinai, we did send this patient for coronary artery bypass surgery to our cardiothoracic colleagues.
Samin, the real reason why she was turned down for surgery was her age or the concomitant?
Actually, you know, she's actually quite small, petite in terms of underweight, but more important is the low ejection fraction and her age. So I think all combined together, they said medical therapy that was back in April. We said, okay, but more important is we wanted to see how much is the viable because ejection fraction was 20%. So we got a cardiac MRI, and it's very interesting. It shows that entire ventricle, except a small segment of the LV apex, was all viable. So that's a very encouraging that once revascularized, this patient should do very well in terms of improvement in LV function from 20% and should go up. So that therefore, then ball came back in our court that we will perform the high risk unprotected left main PCI with assistant device because of the severe LV dysfunction. So that's where we are today, and I just wanted to introduce my 3 fellows, actually 2 of them at present, Jason Kovic and Deepak Khanna, and of course one will be starting in July, Mitch Weinberg. And of course my cath lab staff here, and as we usually that we show the brief presentation, and I thought that knowing that it's a complex case, and I'll keep it just into 5 minutes, and knowing that these all slides are available, archives, and you can download those slides, so that just simple status of unprotected left main PCI, LV assistance, and few highlights of the DES from the Euro PCR last week. Now basically we know that which patient we need assist devices, particularly those who are high risk as mentioned, and the patient typical where there is a complex lesion and there is a bad ejection fraction, and of course patient with a hemodynamic instability. 3 devices, the IABP, PTVA, and Impala. And Impala of course will show you the exact that it basically pulls the blood from the LV, eject across the aorta, so decrease the afterload and decrease the functioning and myocardial demand, and of course increase the coronary and end organ perfusion with the simple concept of ejecting the blood. And then of course we have compared our data of the tandem heart versus Impala. We have sent this paper for publication and found basically Impala, despite more complex cases, that did extremely well, no ischemic event, and these patients have done very well, high risk with this support. And of course this is my famous slide in terms of where we should use these devices, that patients with a good EF of 35 and above, in complex cases balloon pump is enough, simple none, and in a very bad EF of 20% and so, that you need some kind of assist device. Because even for a few seconds, when you are going to obstruct the circulation for left main and so, and even if it's a simple lesion, but sometimes that may be catastrophic, so that prophylactic insertion of LV assist device indicated when EF is less than 20, high EDP, patients in heart failure and borderline hemodynamic. What happens in a run-of-the-mill cases, 20 to 35% EF, and of course that is the ongoing trial of the Protect 2. Basically in the complex cases, actually I have another patient following this patient who has EF of about 30%. and only vessel supplying is the Lima to LAD, we are going to a rotablation, and I'm going to use in that case impeller device because it does not fall into the category of the trial. But overall, in those complex cases with the moderate to severe LV dysfunction, impeller assist really help you. But whether it will be better than balloon pump, Protect 2 trial will answer it. The trial is actually more than 60% done with the 400 cases. Total need to be about 650 and so. And then basically from the left main point of view, that we know that left main had a bad outcome with the PTCA, balloon angioplasty era. Then we did a bare metal stent. Then the drug-eluting stent, some data were presented, but it still continues until 2007 as a class 3 indication. And so much so, even last year with the appropriateness guideline, you can see on the right side that left main isolated or with additional vessel disease, with or without diabetes and ejection fraction, remain against the PCI. I means inappropriate for PCI and cabbage. And we learned that now over the years, now we actually have a lot of registry data of the main compare by Park, Cedar Sinai data by Lee and Makar, and multi-center data by Chufo from Italy and Germany, and then Bologna registry, and then we have randomized trial of the Limans, and more importantly syntax trial, which has led to change in overall the recommendation of the left main. And clearly this is the very important slide to show from the syntax that left main with the isolated 1 or 2 vessel disease really do well with the PCI. Of course, when you get complexity means more higher syntax score, that's where the cabbage do better. And this is actually a gradation of the syntax score, with the cabbage being in the red bar and Texas DES in the blue bar. That once you go to a higher syntax score, that's where the cabbage really has advantage, because in the simpler cases we know the PCI can be done very safely. And of course, we have the 2-year data which continues to have on the hard endpoint of death, CV and MI equal for both DES as well as for the cabbage. And therefore, this actually leads to our updated guideline of the November 24, 2009, which now have put unprotected left main PCI as a class 2B for selected cases, particularly with a score of less than 33. As you know, that it has been a class 2A, patients who are high risk for surgery, but clearly now with ideal cases that could no longer class 3, and that I would say is a very important reflection that how the recommendation change based on the data and scientific data and based on the trial. And of course, the final answer to this issue will be the Excel trial, which is in process of being starting, randomizing patients with the Zions Prime versus cabbage for left main disease with 1, 2, or 3 vessel, but left main is the minimum entry criteria, but syntax score has to be 33 or less. So the 33 is out. We know the cabbage do better, and this will be the patient sponsored by Abbott, and Zions versus cabbage with a 3-year endpoint of the death, MI, and stroke, just like the Freedom. The trial, the results, of course, trial will start, and it may take about 4 to 5 years for the final results, but at least we'll have an answer to this specific question of the left main. And of course, the issue always remains, do you put a 2 stents, 1 stent? I think we learned that 2 stent approach, if there is a insignificant circumflex, is not necessary. Like this particular case, there is a significant disease of the LAD and circumflex, large vessel, kissing stent, in my opinion, gives you a great results. And then lastly, the 3 slides about the Euro PCR highlight. One of them was Resolute. That is the lot of excitement about the newer generation endeavor, the Resolute stent, which has the change in polymer and the release kinetic of Zetorolemus, and compared to the 2,200 patients. And basically, you can see the definite stent thrombosis was significantly lower with the Zions V stent, was 0.3 versus 1.2 at 1-year follow-up. Now, as far as the target vessel failure, that they both were identical, no difference, and of course, there were late loss, but still significantly lower in the Zions V group. So this is the one important piece of information we got. The Resolute stent maybe is from the efficacy point of view similar to Zions, but definitely high stent thrombosis shown here. Now then, they presented the data of the Split 5 diabetic randomized trial, same, the patient with the Zions versus Texas stent, and you can see here that we have 0 stent thrombosis, and of course the TLR or cardiac death and MI was 1/3 of what we saw in the Texas in favor of the Zions. And this actually is a very interesting piece of information. We have some data on the Endeavor, and that is the Zions v USA registry and relationship of the interruption of the dual antiplatelet therapy to whether it's a high-risk patient or routine patient. And they basically found that once you stop the antiplatelet therapy after 6 months, there was 0 case of late stent thrombosis. And of course, after 3 months, there was still some in our overall, but in a low-risk patient, you can safely stop, I would say, almost between 1 to 3 months. So the overall, what we're learning now, the second generation stents of the Endeavor and Zions are very safe from the stent thrombosis point of view, and this leads to a lower overall MI, and of course, we're concerned about patient should go for surgery or not if they require after the stent displacement. I think it's very reassuring data from the Zions v USA registry. And with that note,
yeah. Just to go over some important point how to handle this patient right from the groin axis. Since she was on Coumadin, today her INR was 2.3. Elderly lady, tortuous and calcific arteries. So the way we handle this situation is we do a micropuncture, and just with the needle, presence of needle or sometimes even the catheter, we take a picture. If you see here, it probably looks like it's just above the bifurcation, and we do another angle which would be an LAO, and we definitely above the bifurcation here, so we know this side is safe. And then we go to the left side, lot of calcium on tortuosity, and the micropuncture, the first picture is very clear that we are already in below the bifurcation, almost
Anu, just based on the pictures you've taken, which side would you choose for the impella?
Usually we like the left side, so that we do our intervention on the right side. If there is any problem with the vascular access, then we have done it impella on the right side, depending on which side is better. But on the left side, the picture you see it, we know we are below the bifurcation, and this is why micropuncture helps us. We take it out, we hold pressure for 5 minutes and go higher. And now we know we are above the bifurcation. Go ahead, and we have deployed only one per close, which is a pre-close. For pre-close, usually you need 2 sutures, but here, since it's on the smaller side vessels and there's already some calcium, the first per close deployed was the artery did not hold it. We had to use a second one, but because of the calcium, we know that we have to be also very cautious that when in calcific vessels, when we are doing this pre-close devices. And now you see here, this is calcium and tortuosity. I had some resistance with going up with the impella, but as long as you have some moderate pressure, you know that it will go through the calcific tortuosity.
No, at the point where you had that little resistance, did you pull back the wire a little bit to help you smooth it, or just gentle forward?
I think gentle forward tug did that, but the same, you can't be too aggressive, it will may destroy the pump.
Now the micropuncture technique, are you using it as routine or because of this elderly patient?
No, routinely for all patients who need pre-close. We know that if suppose you are below the bifurcation, then you can go higher up. If we are going to do pre-close, especially in valvuloplasties and in patients with where this kind of anticoagulation issues, where we know you need to use a closure device later, we are routinely using a micropuncture technique.
Excellent.
And then when you are about to go into the ventricle, I did have some resistance again. You see that? I'm just not able to get it, but with firm pressure, I was able to get the device into the ventricle. And the question is the same. The recommendation by the device company is that if you have a valve area anywhere below 1.5, we should not use it, but we were ready for the valvuloplasty if at all we needed. And since we got a gradient, only our gradient calculated is about 12 to 14. She has a cardiac output about 3.5. And our valve area came just like about 1.6. So, but we were ready with the valvuloplasty if at all we had to do it.
You have to be a little cautious here with interpreting that low gradient with the low cardiac output, though, no?
Yes.
Excellent.
Absolutely.
Samin, traditionally we've used three contraindication for an Impella device: LV thrombus, significant aortic valve disease, and significant PVD. You've never needed any age cutoff, have you?
Yeah, no, actually in the trial is 89. 90,
90.
okay, 90. Yeah, the trial is 90, but otherwise not many of these patients are difficult patients, but yes, we are not making any contraindication for it. Yeah.
Respira profundo.
Samin, two quick questions have come following your presentation. What is your numbers of left mains you have done in the last year?
Yeah, that actually the last year we had, I think about, we have it in the book, about 205.
Yes, a new
But
guide.
since November and December, now knowing the guidelines have eased up, that we actually now doing about 20 unprotected left mains per month. This year should be close to 250. And this is again very, many of them are complex, and rarely it's the run-of-the-mill case that the patient otherwise is a low risk. I just tell you that
Was she
I had
on
a left
Plavix?
main case yesterday, and patient with a left main and two vessel disease in a 68-year-old. Syntax score was just at the border like 32, and we sent that patient for surgery. So that we still with a complex left main, recommendation still has been that they should go for bypass surgery. But if isolated left main or left main with one vessel disease,
flush. Okay,
that it's reasonable that we give this offer to our patients, so that yes, a lot of patients are being referred for this particular purpose. And when we had a webcast, the conference call actually just last week, they asked Greg Stone was with Dr. Chuck Simonton in the conference that how much left main we do, and probably I would say maybe the number may not be exactly as the park, but for the United States they should be the highest number, over 200 unprotected left main every year.
Samin, also from your presentation, is one supposed to surmise that Zionsv is your workhorse stent for the left mains?
Yeah, well, I mean, actually, I would say by and large, except one caveat, that we do have two cases where in the austere left main, where I decided for Zions. Actually, many of the austere left main are still doing a cipher if isolated, that we ended up in putting the additional cipher inside the Zions because the ostium did not open up. It was a mild to moderate calcium. We did a cutting balloon, and a 4O Zions would not open up, and I needed to put a 3.5 cipher and post dilated with a 4O high pressure in those particular cases. So that as I said, this caveat now, Zions prime, which will be the part in the trial, in the Excel trial, has a little different characteristics of the stent design and the balloon. Will it give it a better tensile strength? We need to see. But overall, even for the left main, actually, particularly the bifurcation left main, has become very user friendly. Reason is to the 7 French, you can put a 3.5 or even 4.0 two stents to the 7 French guide. We rarely use 8 French guide for this purpose. So that compared to for the cipher, anytime you are going with a 3.5 and above, you end up in using 8 French guide. While with the Zions, even with the 4.0, we don't need, and 7 French is good enough. This is the 7 French VL30 of Mark 1 of Boston Scientific. And now you can see there is a calcium in both, quite a bit angiographic calcium, both in the ostial, the circumflex, proximal circumflex, distal left main, and proximal LAD. The now question will come that do you do a rotablation of both or just the circumflex, knowing that the circ is the most important of the two. We'll see. So that we actually have this, we use a fine cross with the fielder wire, exchange to the rota and rota floppy. And with a 1.5 bar, knowing that the hemodynamic issues in this particular case, 1.75 may be a little too aggressive because of that angle, that just use a 1.5, basically 1.5 bar.
Anu, how much has been the augmented cardiac output with the Impella there?
It's varies 2.3 to 2.5. She's on P8.
Excellent.
So one thing that we need to do, if you are aortic stenosis, you don't gradually go up by the way they say, since we are already occluding the aortic stenosis, like you said, we may be underestimating her because of the low EF. As soon as we went in, we went quickly within a minute or so to P8. So cardiac output was like 1.9120, and now she is up to, what is it now? 2.3.
But more importantly, the blood pressure, which was 90, is about 110 now.
And the pulmonary arterial pressure, are you?
Yeah, we did, no, we are not monitoring it. We did a right heart. She was in the 50s. She had a EDP wedge of about, say, 20. She's actually on ACE inhibitor also.
Samin, any purpose behind trying to even do an IVUS here to help you guide as to whether you should go between, although, you know, angiographically it is quite convincing the level of calcification, but I'm sure some people may want to see if there would be a role of IVUS for this particular case.
Yeah, they actually, you know what, this is a very important point. And this is what we talked on the Excel trial. They are making it that if there is a 50 to 70% left main, then you need to do IVUS and FFR. But if you have 80+% left main, then you don't need any, and IVUS is not mandatory, although there are data now in the circulation intervention from PARC that left main IVUS may do a little better result compared to with the IVUS, although we don't use routinely, and the data which actually we have extremely satisfying even without using the IVUS routinely. But this case, I would not even use the IVUS, probably may irritate the plaque and will make it more problematic.
Just to let you know, I mean, the picture before we started, and the first picture, she started having her throat discomfort and chest pain. And just to go over just a quick points, is we have just your 3 steps. You move your knob, and then the rota at your Y connector, and we are at a speed of about 150. And same thing, despite it is a distal left main lesion, you see the guide is out, and I'm going to start burying right from the ostium. We have a pacemaker here because of our age, and we are LED or no? Try to take the wire.
Bring back in the guide. Yeah. Bring back this in the guide.
Go on the
The
dyno.
bar in the guide. Yeah. So now, as you can see,
Pressure.
take it
Very
off.
low.
Let's take it off.
Yeah, I was surprised. The general tendency would have been to seat the guiding catheter before, but it was impressive how even with the guide outside the ostium.
Yeah, that actually we try to tell everyone that make sure that it's better on a long run that if you don't use the guide support, because the patient then come back with osteal disease, mid-guide disease, and so that is very important. Now keep the rate too low.
Okay, stop now.
Yeah.
Can you?
The pace, bring the guide now. Let's take a picture.
Okay, wait.
The pressure is good. It's
I think pacing.
So go back with the same burr, or would you size up here?
No, I don't think we need to go to a different bar.
Right.
No.
Yeah.
Means for the LED?
Yeah.
Proximal circumflex.
Yeah. So I think we just try to do because there is no dissection.
Right.
We should try to do a LED also because it's a very calcific issue, and will create
Why don't
a
you take it
problem
out
later
and
on.
just
Yeah.
rotate it? No? No?
Right. Yeah. So now we can try.
No, the clip, rotor clip.
Now rotor clip, you want to move it, you require the rotor clip because sometimes it just would not torque, and that has been, as I said, that the rate limiting step in this technology of the rotationectomy has been the rotablator wire. If they could have made some advancement, of course Boston Scientific kind of dropped the ball completely on any more advancement on this field, but otherwise this is the device which is still there. There is no substitute for it, septal. And you don't have to go. That it's simple little monorail and few other things. That's
No,
okay.
I mean the diagram.
Yeah, that's fine. We don't need. We just need a proximal segment. Good.
No, we don't know how.
Okay, you go further.
See that?
Yeah, I kind of agree. Better off having that in the LED.
Yeah. You need to advance the guide slightly.
So, I mean, another fascinating question has come that do you agree there should be almost a default strategy of a standing recommendation for getting a surgical opinion for a syntax score 33 or greater?
Well, I think if we want to practice the evidence-based guideline, this perfectly makes sense, because not only that, those who are aware of the data which I have shown here, that at 2 years, once you got the syntax score, the syntax score of 33 and above, that once you started developing more myocardial infarction. This is the clip.
We can leave it there.
That MI, whether it is because of the procedure, because of the stent thrombosis, some will know. And of course, I think the real deal breaker will be this 3-year European Society of Cardiology data this year. That really will tell us that where we are in terms of the 3-year data. I think this is okay now.
Okay, good.
Yeah, it's still in the diagram, but that's okay. Good. Let's go to the model view. Remove this. Yeah. So now we
don't need
say
caudal. We can do this view.
Going back with the 1.5 burr down the LED now.
Same 1.5 burr to the LED.
We have the wires ready. Run through and the fielder, yeah.
Yeah, therefore, I think just if we go by that the region now, many of these patients will not be a case for, will not go for coronary artery bypass surgery, largely because of their comorbid conditions. And many of these cases will be declined by surgery because of bad LV. I can tell you that now, knowing that the syntax score does not incorporate. And if you ask me, one of the biggest fallacy or limitation of the syntax score is,
Which leg, dear?
yeah,
Which leg? Oh, as soon as I touch.
give a little lidocaine there.
No,
She's
no.
having
It's
little pain.
knee pain.
Okay. Okay. Yeah, she was complaining of some knee pain.
6%.
Yeah. Now another thing which the patient was on Plavix every day.
Yeah, for a week. We loaded her last Wednesday.
Yeah.
And she has been on Plavix 75 daily for a week. And her Plavix today is about 6%.
And actually, just to show that this patient is a non-responder.
Yeah.
Non-responder by definition, less than 20% inhibition, 20 to 40% is hyporesponder. So this patient, but only problem is because of her age, the prasugrel is not a right choice. So what we'll do in this particular case is just go.
No. Again, same point. Our guide is outside.
Yeah, we can, this is very nicely illustrated, although I'm wondering if there is a need to upsize here, or you feel happy with the...
I think the most important would be that we'll go to the areocaudal view.
Right.
And then leave this wire into one of the vessels, and then try to see that if required, that whether
I
you
think
can...
we could just, we should just do with the balloon and stent.
Yeah. So I think
No
once
need
you have
for
taken
a-
this calcium out from the superficial, you have decalcified the area. Leave the one, and we will know it. Let's get both the wires quickly.
Anu, what has been your experience of the Impella for a STEMI indication?
Actually, in the STEMI situation, we have had one patient with a cardiogenic shock, where we had to do the Impella because of the cardiogenic shock. But overall, the patient had so many other comorbidities. We had to take it out after a few hours because of peripheral vascular disease and other reasons. Patient.
Guide has to come in a little bit.
We have not used for routine MIs.
So where have you seen in your practice the Impella replacing? It's replaced clearly the tandem heart. Has it started impacting your use for the intra-aortic balloon pump too?
Now, I would say that definitely the tandem heart, by its complexity, multiple punctures, and so, it has been. Need to get a guide in quickly. Good. Yeah. That's gone. Therefore, now we actually have used tandem heart for few cases because of patient were as a bridge to transplant, but not for the PCI. For almost 2 years now, we have not used the tandem heart for that purpose. And
The indication for the Impella, I think the slide which has been shown, all depends what the EF is and what kind of vessel that we are doing. So if it's less than 30%, that's when I think we have started using Impella in most of these high-risk PCIs.
Or I would say maybe over 20.
20.
Well, from whatever reports I continue to hear, its use is burgeoning, I think, which is because of the extreme ease of use and the user friendliness. I think has an extremely low learning curve to it.
Yeah, and exactly. I said that somebody say, what is the learning curve? I say, have you put the pigtail in the ventricle? I said, that's it. That's your learning curve.
I mean, various
if you learn to put a pigtail, you can put an Impella device.
Right.
Okay. Now we are ready. We have put both wires. One is the fielder and one is the run through. And we are now going to take care of the circumflex first, knowing that this is the most critical of the two, and using our 3.0 20
we have a
and
3.0
spoiler,
20,
right?
yeah. Same thing now, after we have done the rotational atherectomy, use a non-compliant balloon. Okay, so we can, if you need to really crack and make sure the lesion is nicely open, we can go high pressure.
Would you address the distal part of the vessel also at some stage?
Yeah, that's a very good point, I know. And that in many of these complex cases, it's not bad that you just take care of the acute, the significant lesion, because everyone will require additional stent, additional dye, and so forth, so that it's completely fine that you take care of the tight blockage, like in this particular case. Our focus should be take care of the left main, proximal LED, and then leave, knowing that these patients should come back.
No, quick.
Samin, a very critical point. How did the patient tolerate this dilatation?
Right now, blood pressure has become, they did not tolerate well, and the pressure, despite on the maximum, did go down to about 80 from 100, but now recovering back again.
Okay.
But we expected that. We knew this is going to happen. And this is that 1 minute of the procedure, or few seconds of the procedure for which this device has been placed. I'll bring the guide in a little bit. See, there is a lot of disease distally which we can now come back out, and then that's okay.
That you are happy?
Yeah.
At that angle, the way it is.
Yeah.
Will
And then now we are going to do the LED. Now, as you can see, that what will happen is that these complex cases, we still give them the time.
As soon as we engage the guide.
We give the time, although the recent guidelines have eliminated the routine angiographic follow-up. As you know, part of the Excel trial also, that routine angiographic follow-up is not there, because clearly same, many times you have ostial circumflex disease and you feel like doing a PCI, while we know that those can be left alone. So that routine angiographic follow-up is no longer part of the equation of the left main now. And what we have done is this kind of case, where there is still a lot of residual lesion, that patient will bring back in about 6-8 months, about 4 to 8 months, usually 4 months and so. And that particular, that time, you can do a part 2. That is, put additional stent through the barrel, if need to be, because many of these are the bifurcation cases. Actually, both these, the lesions, once we did this PCI, the blood pressure did go down to about 80. So the very, very hemodynamically significant. So that could we have done this case without Impella? Yes, but then we would have risked the catastrophe on the table. So with the Impella device, with a cardiac output of about 2 liters, and we still went and had this issue of the hypotension, is really remarkable that we were able to dilate that even for a few seconds, and you saw it, we went double negative. So now we're ready to take a picture, and then decide what should be our stent strategy. Now, this is the case, the last slide which I showed, that once you have a both large vessel, a little bit, so we can take a picture, yeah, good, and then we'll disconnect. Every time we engage the guide, the patient does become hypotensive, and we are not going to just put a, now let's evaluate, scene minor. Yeah, pressure right now is okay, but clearly that in this case, before we do the PCI, I will put the stent. We are going to use.
The circ you need to dilate better.
Okay, the circ requires a little more dilatation.
3.5, 15, high pressure, 3.5.
Not the cutting balloon. Why don't we use an angiosculpt? No, we can use a 3.5 angiosculpt in this case for the circumflex.
Do this?
Yeah, leave that alone.
Bad.
Huh?
That's the only viable area.
You want to dilate the balloon now?
Stent it, direct stent, no?
No, you still have to dilate there. If you want to now here, what Anu is pointing out that at that posterolateral, there is definitely a lot of disease. The question is, should we do a balloon angioplasty and stent there before we put a 2 stents?
No, leave it.
Yeah, let's do this ostial circumflex real quickly, and then here we are using the angiosculpt.
Yeah.
Yeah. Now, many of these cases, we still give a little bolus of neosynephrine for those few seconds, although the use of oral neosynephrine definitely decreases by use the impeller device, but I think we still feel comfortable as long as the blood pressure remains in around 90 and so.
Oh, yeah. On the wrong wire. Yeah.
So this is you're placing the angiosculpt now?
Yeah.
Yeah.
What has been your experience with that? Has your use been the same, increasing a little bit? Have you developed an algorithm where between the cutting balloon and the rotablator and the angiosculpt?
Well, I would say that since we have used a lot of cutting balloon over the years here, and in our this live symposium, I thought that let's show how the results of the angiosculpt are. Now, angiosculpt where we really like it, patients with instant restenosis, very good results. Now, many of the ostial I have not been happy, and sometimes it does not go, and while 6 millimeter your flextome will go. And this one will be a proximal lesion, very quick. Yeah.
But now you saw that on the inferior portion, the lesion, which was not opened by the other one. This has opened. The good thing about this, you can go real high pressure up to 20.
Yeah, and I was 18 atmosphere with a 3.5, 10 millimeter angiosculpt.
You want to go up again or no?
No.
Okay. But for true ostial lesion, I think you need the cutting balloon where the blades will cut the not only the plaque but the
therefore we still rely more on a cutting balloon than angiosculpt, and just because being a 6 millimeter flextome just works very well.
Okay, we go
now
with the wire.
We take let's put the guide in so that we decide about the LPL.
Okay, leave it with this.
Yeah. Okay, then we just decide about our stent strategy.
Yeah.
Good. Okay, get both 3.5. No, 3.5.
No, 3O LED. No.
Okay, 3O. 3O LED.
Left may not accept it.
Good. Here.
So, I mean, another very
3O 23, right?
23 or 28 you want?
Yeah,
28.
LED could be 28. Plus.
Yeah.
And circumflex is
23.
3.5 23. Yeah. So we'll use a 3O28 in the LED Zions V, and then we'll use in the circumflex 3.5 23. Yes. What's the question now? Go
this is unusual and fascinating that the specific question is that the impeller device is one of those rare devices which also is financially good for an institution. Do you have any suggestions on reimbursement and coding issues?
I can tell you till the new Obamacare comes in, it's still good. Because it really should be used in a high-risk patients like this, and because of their comorbidities and so, their DRG falls into, go a little further, DRG falls into the very high category, so that most of the reimbursement, these cases,
the diag, you cannot pinch the diag.
Yeah. That most of these cases have a DRG of 90,000, 85,000, or even 100K. So that financial point of view, you are not penalizing the institution by using the, but clearly you have to appropriately bill and code. And of course, it's cost about 22,000 additional cost of the device and little extra lab time. So even if, let's say, overall cost is about 30, that financial point of view, it's completely okay. There's no issue from finance point of view.
Anu, take us also through the steps of how your technique of the kissing stent with the balloon pressure inflations.
Yeah, okay.
Same level.
Oh, no, okay, this is a circle. What?
The dot. Good. Bring the other dot a little bit. Yeah, therefore, as you can see that we are trying to do both.
So we place both the stent and the proximal dots have to be together. You see that now?
Yes, and
Yeah,
I saw
yeah.
you pull it back into
Pull
the
it
left
back.
vein a little bit. Yes,
Little neo right now. Tell them.
Yes.
that
Some
looks
neo, quickly.
that looks exact positioning. Okay,
Yeah.
how high will you go now?
Good.
Now,
Ready?
since this is Zions,
Yeah.
we will go between 8 to 10, no higher than that.
Okay,
So both same time,
Yep.
the fellow
Guide out.
go up, quick.
Guide out.
Now guide is out,
Yep.
Samin, how
Down.
is
Both 10.
both 10.
Both
how is she tolerating now?
Right
she's
now,
okay.
it's still
She's
okay.
80.
Blood pressure, although coming down to about 85.
bolus, flush.
But this is the
Go.
kind of case that I would give a the 100 microgram or 200 micrograms of neosynephrine.
Right.
Prepare the patient for this particular purpose. Yeah. Now
Okay.
you need to let it recover because there is no choice otherwise. You have to let it recover. Let the blood pressure come back to about 100 again, and then we go to the part 2, which is the individual dilatation, so that the stent can be expanded.
And how high would you go with the Zions? here?
Again 14, not more than that. So that now here 14. As I mentioned that 14, more than 14 is, in my opinion, absolute contraindication.
On the impeller, it's showing a blood pressure of 110/75. Yeah.
Well, I think that's also because you've significantly improved the flow too.
Yeah. Wait 1 second now. I think we need to have.
Double negative. Give us another 60 syringe, the big syringe.
Yeah. Good. Just 1 second.
Yeah,
Yeah, we can give. That's fine. We'll be okay now.
yeah. Okay, good.
Yeah. Good. Go up.
Keep giving.
Now
don't
we are
go
doing the
pressure
LED.
down. So you're going up to 12 and we see some expansion. Yeah, good.
Looks well expanded there.
Down.
Samin, did you have a little problem in deflating the stent in the circumflex?
No, it's just basically because once we are to high pressure, 3.5 and 14, it takes a little extra. So that now, usually it doesn't matter, but in this particular case, 5-second delay is way too much, so that we attach the second
Right.
syringe and go negative. Now things look good.
Other thing also you could do is use a half and half so that your deflation, inflation are faster,
Can be
in this
faster, right.
situation. Yeah.
Okay.
So I noticed here
Fourth one,
your
again,
dot,
simultaneous inflation and simultaneous deflation.
your
of the
dots
Yeah.
have moved slightly.
Yes,
Would you-
slightly, which is all right.
That
10 and
happens.
10, negative. They just go negative again. They're both simultaneous inflation and simultaneous deflation.
And how high did you go in the
Now
last
the 10
one?
atmosphere again.
Okay.
10.
And if need be, you will go with the high pressure balloon individually and do spot stenting.
That's exactly what will require in order to open the carina. Now we may need to use a different size balloon if necessary, but length should be the same, so that you are never any issue in terms of crushing any part. So that what I suggest is that use the same length, maybe a different size like 3 or 3.5, but use the same length of the 2 high pressure balloons. So now everything is looking good. The pressure is about 110. We have deployed it, and we are ready to take a picture to really see where we are. Always, I tell everyone, once you take your device out, make sure you have seen the de-air it, that air embolism, major catastrophe interventional cardiology. So that we have to have de-air after device removal. Very, very important point, simple point, but so much so that this question, they always ask in the board, they'll show you the angiogram with a little bit air in a OM3 or a small diagonal, and patient has collapsed. The diagnosis there is air embolism, so that very meticulous in terms of air. Now you can see here, the only thing remaining is that the little ostium of at the bifurcation in the LED, there is still a chunk of calcium on the top and below, may require a little extra work. So that we'll.
What do you want?
Okay, 3.5 NC Voyager, and we already have a 3.0. Yeah, yeah. Good. Then we'll just post dilate. Good. Although you can see everything is just looking quite good. Go to the
I
front.
think we have to give her efficient. We can't give 2B3. We have to give her efficient. She may close this.
Okay, what?
We'll give
So,
her a dose of
can
Effiant.
we get a LAO caudal
Why not?
projection here too?
Just 60.
Yeah.
So we're not giving 2B3A.
Okay. Now, why don't you give one dose of 2B3A? Yeah, we'll go there also. This is which where you are in.
This is
3.5. Yeah. What is happening with her?
nothing, nothing. She's fine. She has some knee pain every time we are.
Okay, this is a 3.5, 20. We'll going to put in the circumflex.
We should
and
have
then
gone with this shorter, no? Just for the.
fine, no problem. Yeah, and then we have a 3.0, which we have dilated before.
Anu, your anticoagulant strategy here was bivalirudin only?
Yeah, yeah. What was the repeat ACT? Okay, she was 330 her, and she got 300 of Plavix. That's what we are debating, knowing that she's a non-responder.
Go to the other one now.
Do we give something? We have to give her something. This is
3.0.
3.0.
Now we are 3.5, 20 NC Voyager, and now we are 3.0.
Shouldn't we have gone 3.5 to the LED?
3.0 is good.
So really open the.
And then we'll go with the caudal. Yes.
Is this what you're doing now as a standard to use exactly the balloon of the same length rather than a short spot stenting?
No, I think it could be shorter also. Here that will be would have been fine.
So now you have a 3.5 in the LAD and a 3.0 in.
No,
They are both
3.5 with the circumflex,
Okay.
and 3.0. You want to bring
for
that?
the LED.
Yeah, and 3.0 in the LED. Although
Good.
we are okay here.
Yeah, yeah.
Good. Go up now. Yeah, go. We are going up.
Now LED higher, circ, okay, 14. LED you go up to 20. Yeah,
Yeah. The 20 in the LED, negative.
down. Who was
And
in the LED?
14. And that's it. That is all it needed.
So, I mean, what would be the duration of the antiplatelet therapy here?
Yeah, in this patient, I would definitely will continue for long period of time, at least 2 to 3 years. And not only that, this patient is going to come back for additional. Take a picture. Yeah. For additional intervention in 6 months, so that we are talking about at least 2 to 3 years. But otherwise, routinely, good. See, otherwise routinely we are just giving it for about 12 to 15 months. And we actually have a large number of. You want to take the wire out? Yeah.
So, I mean, as you take the last few pictures, what's going to be the emphasis on your complex coronary intervention case for next week? What should that be advertised at? I'm sure it would be a further more intense representation of what people have been watching during the live cases, but are you doing more unique cases, emphasis on structural heart disease?
Yeah, actually what we are going to do is on Wednesday we have the Impala symposium, and that actually will be a very good various topics, and the US Pala registry, which has been just presented in EuroPCR, will be the data will be presented there. But overall the emphasis still will remain the performance and the technique point of view of this complex cases. As you can see here,
It
excellent,
looks perfect, yeah.
Angiographic results, good flow in the LED, and last picture here.
Start winning
And
out.
then more important being that we will try to, the step-wise step, total occlusion, calcific vessels, and more left mains. Now we do have a live transmission of the core valve. We are one of the center for the core valve in the future, but that will start probably in few months. And we are also in a process of trying to get into the partner 2 trial. But more important being that for the core valve, since it's not approved in US yet, we'll have a live relay from Germany by Dr. Grube.
Actually now the blood pressure is consistently at 120, already weaned off impella, she's at P2 now. Yeah.
Anu, where
That's
would
one
you would remove it immediately in the
Yeah,
cath lab?
we'll be removing it here in the cath lab so that we can do the closure here. And once we have done the closure in this patient, just because she's a Plavix non-responder, once we know we have hemostasis with both the groin, that we are going to give intravenous 2B3A. This is a lady who has a high risk for stent thrombosis, is a bifurcation stents in a calcific vessel with the low ejection fraction and a non-responder for Plavix.
Yeah, and if we I think the take-home message, if you want to put a last slide, basically is that in these complex cases, that you need to have your strategy correct, what you need to plan to do, an optimal technique, as I said, that before starting the case, and do what you do the best, because clearly the results will be what your experience has been, so that in critical situation and things happen, that nothing is new to you, and of course, whether you need a LV assistance, PA monitoring, temporary pacemaker, rota, 1 versus 2 stent, I think we emphasize on all the points. And then of course the clear-cut interventional plan, as I mentioned, and the duration of the use of appropriate devices and change in the technique based on the evidence base in the literature. Now with that note, if you continue some questions, answers, we are going to just come up there and we'll just I'll join you in the conference room, and maybe you can continue to answer or ask any further questions.
Well,
so
the first observation I have to make, and I have been watching you do these complex cases, left mains and bifurcating lesions for a while, is that how well the patient tolerates the procedure with the left ventricular assist device in place. I think it's remarkably improved over the balloon pump, and so much easier to do than going tandem heart.
You can answer.
Yeah. Now, other thing also is the same. You know, we have mentioned that this is a protocol-driven lab. I think you have seen us how we do that we have decided this is the way things have to be done. And I have, other than thanking the cath lab staff, I have to thank our fellows. And we have 7 graduating end of this month. DK is right here, who is going to California to join a private group. And we have Jason, who actually joined us from NIH, who has his basic science research project all set to work here, and he's going to stay with us, continue his basic science project, as well as will be doing a clinical research with us. We'll be proud to have him as our faculty. And we have Mitch Weinberg, who is joining. He'll be the interventional fellow who has a cardiology fellow from Sinai, and we have 3 cardiology fellows of Sinai who have joined as interventional fellows for this year, and we will have a group of 8 starting from July. And as you see them, they go with the protocol, just do the same things, and all these tough cases they will be able to handle. I mean, of course, I'm here for them, but they'll be able to handle independently at the end of this month.
I wish your fellows very well. I know how much they contribute to this amazing, well-grind machinery you have here. A very interesting question has come from a very profoundly elegant interventional cardiologist whom I have known over many years, Dr. Constantino Constantini from Curitiba in Brazil. And he has actually remarked on what we have kind of discussed already about Dr. Park's data, where he's recommending IVUS in most cases. Dr. Constantini's specific questions was, were you planning to do an IVUS after the stent implantation? I think that's been already covered, but Anu, do you want to specifically answer that?
Yeah, I mean, if time permit, that this kind of cases have to be, I mean, IVUS guided would be good, especially since it's a calcific vessel, to know, how good the deployment is, and what studies have shown is the same. After doing this kind of a bifurcation stent or double stent, IVUS is a good tool to see the stent opposition, and most important thing that we can learn from doing stent in IVUS in this situation is if a good opposition is not done, to go to the next step to do post dilatation. And in this particular case, we could have been done with IVUS, and knowing that this lady could become unstable during the procedure. As you know, many times she was becoming unstable with the pressures in the 80. That was one thing we did not want to do, which would have had a few extra steps. Otherwise, yes, this case has to be done with the IVUS to know that a good stent position has been done, and that will prevent stent thrombosis.
Anu, I think that makes perfect sense. Also to let people know that there has been a change in the format starting the next time, which is July 20th. We are going back to the 8 a.m. format, and that's because of a huge amount of requests from you that it was disrupting an early start to the cath lab, and also because several cardiac cath labs have a breakfast session going on. So we'll be back at 8 a.m. and now I'm back here.
They want to complete there so she can.
We are finishing the case, and I think with our 1 year anniversary completion, this case, a successful case, cannot end without our Sinai clap.
And Anu, you can come here in the conference room and bring our other cath lab staff to join us. And just to add to the beauty of this 1 year our webcast completion, we actually have a very special guest, which is our Chief Operating Officer and the President of Mount Sinai Hospital, Wayne Keithley, to support us for this adventurous 1 year. The teaching of these cases, the complexity, and many of our frequent viewers who have seen us sometimes struggling, but coming up with the excellent educational point and the technical points, and we really felt that this 1 year completion need to have a special celebration. So I invited our special, my dear friend, of course, the President of Mount Sinai Hospital, Wayne Keithley. Wayne?
Thank you, Dr. Sharma. Congratulations. I'm told there are 14,000 viewers watching our webcast today. That's phenomenal. It's a great success, and we're very pleased and very proud of what Dr. Sharma, Dr. Kinney, and all the faculty have been able to accomplish. This is a wonderful event, and we're honored to host this at Mount Sinai Medical Center. Thank you, Dr. Sharma. Congratulations.
Okay.
Dr. Kinney, Mount Sinai clap one more time.
Yes.
Yeah.
All right. And we actually ready to celebrate here, although I can't eat anything today. Today is my 24-hour fasting day, but that's all right. The God is a little extra on my side, so that's is a good thing. That's why we decided Tuesday as our webcast day.
Excellent.
But really, I congratulate our cath lab staff and more importantly, all the viewers that who have, whether they logged in, but even later on have logged in, and the majority of, I get a report from our audiovisual and the Mount Sinai TV from Ricardo, that majority of the audience, when it comes back on the website, they are there for about an hour. Therefore, try to take advantage of all the technical points, the question answers, and the slides. And of course, as we have mentioned, that slides are in the PDF format, can be downloaded. Whether we will be able to download the entire case, I don't know. I know there have been a few requests, because based on the bandwidth of the individual desktops, sometimes it's very slow for individual person. But there may be some proprietary issues, but we'll look into it. But I can tell you one thing, that those who are coming next week in our June symposium, 17th and 18th, all these 12 cases will be presented to them on a flash drive with entire 1 hour.
Wow.
So 12 cases, which is their slide, the entire case, all the points will be given to all our attendees. With that note, I really thank, and we celebrate the successful 1 year of the live webcast, and thanks to all. Okay, let's play.
We need a bigger knife.
Yeah. Okay. Thank you, everyone.
Microsurgery.
And therefore, now, since in order to get all the questions for this webcast ready for next week, we want you to put the questions now, and because we have to answer ready by 1 o'clock, so that it can be put onto the flash drive for the next 8 days later.
So we'll see you July 20th, 8 in the morning, and thank you all for your feedback and your support, and goodbye.
Okay, thank you.